All right, so we're in the pathology connection where it talks about a lot of the different illnesses that affect the upper airways. Common cold is an obvious one. There's way over 200 strains of the common cold. That's why there's no vaccine, no cure, anything like that. It mutates constantly, and there's many different strains. But fortunately, it's usually not life-threatening, so we just manage the symptoms. Good hand washing is the biggest thing you can do to prevent it. All right, so cold versus allergy versus flu. This is something that symptomatically a lot of people mix up, especially cold and flus. So typically allergies, I'm not going to talk about a whole lot because you guys kind of know how those work. So when you get a cold, usually it comes on kind of slowly. A lot of you know you wake up like with a little tickle in your throat or something, and you just kind of steadily start feeling like fatigued or sick or whatever. You start getting the symptoms over the period of a few days until you really have it. Flu usually comes on really hard and fast. It can be full force like the first day that you have it. Colds typically last about a week. Those symptoms can last significantly longer. They can kind of drag on as your body fights off sort of the remnants of it. Flu's about the same duration, often a little bit longer. They both tend to happen in the fall and the winter, which again is not really because it's cold outside. It's because in cooler weather, people are indoors huddled together more. And in the case of those of us who live in Florida, even though it doesn't really get cold here, all the snowbirds come down and bring all their cooties from up north. So even for us, even though it doesn't really get that cold very often, it still is seasonal because it's seasonal all over the country. And lots of people from other places come down here in the winter and bring all that stuff. Fevers almost never happen with the cold, and it is a standard sign of the flu. The fatigue and weakness that you feel is a lot stronger with the flu. It's a kind of a hallmark of it, whereas the cold, you just feel a little bit tired and fatigued because your body's fighting an illness. And you don't get that extreme exhaustion, but pretty quickly on with the flu, as those symptoms come on, you just feel wiped out and exhausted. Aches and pains occasionally happen with the flu, with colds, but it's prominent in the flu. Sneezing can happen with either one. It's more common with the cold. Sore throat and stuffy nose, those type of things are usually a cold, but you get those sometimes with the flu as well. That yellowish, greenish nasal discharge has to do with the infection being in your sinuses and in your nose and throat. More common with the flu. And the chest discomfort is usually much more significant with the flu. You tend to get that hard, dry, hacking cough, and it hurts real bad in your chest. Vomiting, almost never associated with a cold, but it's pretty common with the flu. Sinusitis is, of course, inflammation of the sinuses caused by either viruses or bacteria. It causes pressure, pain, and headaches. Remember, your sinuses are those hollow cavities inside your skull. So when you get inflammation in there, it builds up this pressure, and your skull is a mostly enclosed space. So any kind of pressure in there tends to be very uncomfortable. Tonsillitis, inflammation of the tonsils. Sometimes people still do tonsillectomies. They're not as common as they used to be because they have found that they're not always really worth it. And it does slightly compromise your immune system, having your tonsils removed, because they are part of your immune system. So they still do it sometimes in people who have really frequent tonsillitis, and it's just becoming a problem where it's worth it. Pharyngitis, that's just the fancy word for a sore throat. When it's strep throat, that term comes from Streptococcus bacteria. That means it's a sore throat that is specifically being caused by Streptococcus bacteria. Laryngitis is inflammation of your voice box. That's what happens when you get real hoarse and you can't speak well. It can be caused either by an infection, just like any other sort of sore throat and inflammation, or sometimes it's just excessive use. Sometimes it becomes inflamed because you've been using it a lot. You've been talking a lot. You've been yelling a lot, whatever the case may be. So this image just kind of shows you where the different infections happen. Epiglottitis, obviously inflammation of the epiglottis. So it can cause an airway emergency because your epiglottis is really important. It controls what goes down what pipe in your throat. Haemophilus influenza type B is the most common cause of acute epiglottitis. There's lots of different things that can cause different versions of epiglottitis, but the acute form is most commonly caused by this particular bacterial infection. There is a vaccine for it, so we've been seeing the rates decline significantly. It most commonly presents in children from ages 2 to 6. Symptoms of acute epiglottitis include acute swelling of the epiglottis, fever, and sore throat. It typically has a very sudden onset. It happens very quickly and it needs rapid treatment because it's closing off the airway in the throat. Treatments generally, therefore, include maintaining the airway, keeping it open, and then also using antibiotics because, again, this is a bacterial infection. That influenza might throw some of you off. It is not a flu virus. This is a bacteria. Laryngotracheobronchitis is an infection of the laryngeal area characterized by noisy breathing, especially on inspiration. Symptoms include a barking cough and inspiratory stridor. Now, stridor is a high-pitched sound. You don't have to use a stethoscope most of the time to hear stridor. A lot of breath sounds, you have to really be listening with a stethoscope to distinguish them, but stridor is a very obvious, distinct sound. We used to call this croup. So a lot of times you'll still hear people, it's still in the common language, most people still actually refer to it as croup, but it's abbreviated LTB, and that is the preferred medical term now for it. Sleep apnea, some of you have probably heard of this. A lot of people have sleep apnea, sleep with a CPAP machine. Your breathing stops when you're sleeping. Frequently, you'll wake up. A lot of times you'll wake up and gasp. If that's ever happened to you, that you woke up and just took a gasp in, you might have sleep apnea, and it can happen to anybody at times. But as a diagnosed medical condition, it's something that you're dealing with basically every night, and it can be dangerous. So it's caused by the soft tissue at the back of the throat relaxing. So if your throat relaxes, it actually shuts off your airway. Can cause fatigue during the day, obviously, because you're getting terrible sleep. And it can cause high blood pressure, weight gain, headaches, all kinds of stuff. Basically all because sleep is a super critical process for your body. We do our healing, our growing, all kinds of stuff, digesting best in our sleep. So if you're screwing up your sleep pretty much every night, which is what sleep apnea does, it can cause lots of health problems. So the way they typically diagnose it is you go to a sleep center. There's these clinics that have these little rooms where people can sleep, and they hook you up to equipment and they monitor you while you're sleeping. It's called a sleep study. They use special pillows and positioning sometimes for patients that they work for, and it helps keep your airway in the right position to stay open even if it relaxes. Losing weight can often reduce the severity. Being overweight is one of the factors that can contribute to somebody having sleep apnea. More severe apnea, use oral appliances, breathing devices, or surgery. So a CPAP machine that I mentioned before is continuous positive air pressure machine. So some of you have probably seen these. You have to sleep with a mask on your face with a tube hooked to it that pressurizes the air so that if your airway were to relax and kind of close off, it's forcing air down into it. So basically that pressure is holding the airway open and keeping it from closing by just adding pressure to your breath. All right, now we are officially on the lower respiratory tract. So it looks kind of like an upside down tree, sometimes called the tracheobronchial tree. From the vocal cords, air enters the trachea or our windpipe, those mean the same thing, which is about 4.5 inches long, and it's lined with the ciliated mucous membrane that's part of that mucociliary escalator that we talked about in the last lesson. So the trachea extends from the cricoid cartilage, that's that piece of cartilage in your throat that helps hold it open near where your Adam's apple is, to our 6th thoracic vertebra, if you remember that from the skeletal system. That's the 6th one down from inside of your thoracic cage. The C-shaped cartilage found in the anterior portion of the trachea provides rigidity and protection, the exposed airway in the neck. The esophagus lies in the area where that C opens posteriorly, so it opens towards the back. There's room for the esophagus to expand when you swallow larger chunks of food. That's why there's an opening. It's not a complete ring because it's very strong, rigid cartilage. And if it was a solid ring of cartilage, then a big chunk of food would just kind of jam there. So it has an opening at the back side, facing the back, so that it has some room to flex out, because the ring itself, that C-shaped cartilage, is not very flexible. All right, here's your image of the tracheobronchial tree. All right, the trachea is the largest pipe in your respiratory system. It's like the trunk of the tree. So it begins branching, bifurcating at the center of the chest into the left and right main stem bronchi. The main stem bronchi The site of bifurcation is called the carina. So bifurcation means splitting into two. So you see in this image, this is the carina. So this thing right here is where it bifurcates, which means turns into two parts. The next bronchi must branch into 5 lobular bronchi, which corresponds to the 5 lobes of the lungs. So again, we see this 1, 2, 3, 4, 5. That's the 5 that we're counting. Then it branches more farther down. But each one of these serves a different, lobe. So there's 3 here because there's 1, 2, 3 lobes. On the left lung, we have 1, 2 lobes. Okay, you can see the difference. So there's only 2 branches, 2 main branches here. Okay, because there's just 2 lobes. Each lung lobe is further divided into specific segments. Next branching of the bronchi is called the segmental bronchi. At the point from the trachea down to the segmental bronchi, the tissue layers of bronchi are all the same. They just get smaller as they branch downward. The epithelial layer contains mucociliary escalator, which we talked about again before. The middle is the lamina propria layer, which contains smooth muscle, lymph, and nerve tracts. The third layer is protective and supportive cartilaginous layer. So here we see the different layers. You've got this epithelium. That's that pseudostratified ciliated columnar epithelium that's making mucus to line this tract. Again, I told you guys it's like flypaper. It catches anything that goes in there, and the cilia move it back towards your mouth and nose to get rid of it. It either gets coughed up, spit out, shot out your nose, or swallowed. So we have smooth muscle here lining this so it can constrict and dilate just like our blood vessels can. That's one of the things that happens with allergic reactions is you can get constriction of your airways, which makes it harder to breathe. That's why people have like asthma attacks or they can have trouble breathing when they're having an allergic reaction because these can constrict. The branching becomes more numerous with tiny subsegmental bronchi that branch deep within each lung segment. The cartilaginous rings become more irregular and eventually fade away. As we move towards gas exchange regions, the airways simplify to make it easier for gas molecules to pass through. So when we talk about simplifying, we're talking about all those different layers that we just saw. If it had all those layers in the end in the alveoli, we wouldn't be able to pass any air through them because it's too thick. It's a solid barrier. Bronchioles average 1 millimeter in diameter. There's no cartilage layer. The epithelium lining becomes ciliated cuboidal cells, those little short cells instead of the tall columns. The cilia, the goblet cells, and the submucosal glands are almost all gone. So there's very, very few of them. There's a lot less mucus being made. And it's because these things are getting real tiny. So mucus would clog them up if there was much of it. So we're in little tiny bronchioles now. There is no gas exchange yet. The terminal bronchioles have an average diameter of 0.5 millimeter. That's really small. They have no goblet cells, cartilage, cilia, or submucosal glands at this point. So there's nothing making mucus. There's nothing giving it any real strength. It's getting to be very delicate, thin tissue. The terminal bronchioles mark the border between conducting and respiratory zones. So up through this point, all we've been doing is conducting air, okay? This is all part of that ventilation that we talked about, the mechanical process of breathing, where all these are just tubes that are sending the air to all the little alveoli that are going to actually do respiration. The next airways beyond the terminal bronchioles are respiratory bronchioles because some gas exchange occurs here. So these are the thinnest, most delicate bronchioles, and gas can exchange through them, though they are not the main site of respiration. The epithelial lining is simple cuboidal, interspersed with alveoli-type cells called simple squamous pneumocytes. So if you remember, simple squamous cells are those flat scale-like cells, and these are specifically simple squamous pneumocytes because they're designed to allow air to pass through. That's what pneumo has to do, that P-N-E-U prefix on there has to do with air. If you've ever heard of pneumatics, that's using air pressure to control things. So pneumo has to do with air. Alveolar ducts originate from respiratory bronchioles, wherein the walls of the alveolar ducts are made up of simple squamous cells arranged in a tubular configuration. These give way to the alveoli. So here we see. So you've got the terminal bronchioles, They're getting really thin. They've got a little bit of smooth muscle that can constrict them, but other than that, they don't really have any kind of other tissue there. So gas can exchange a little bit through those. But then you see these alveolar sacs, super thin walled, really delicate, covered in blood vessels, these little capillaries. So what happens is as you inhale air, remember it's coming down this tube and it's filling these little sacs, and any oxygen molecules that are in there are able to diffuse through here into the blood. So here's deoxygenated blood. Carbon dioxide is able to diffuse this way, and then oxygen starts diffusing in here to the point where this is now oxygenated blood going back to the heart to go to the rest of the body. This was deoxygenated blood coming from all over the body. So we inhale that oxygen, and then we blow off the carbon dioxide. Alveoli are the terminal air sacs. They're surrounded by numerous capillaries. Together, the capillaries and alveoli make up the functional unit of the lung. Adults have 300 to 600 million alveoli with a total of 80 square meters of surface area for oxygen molecules to diffuse into the capillaries. So that's the point of all those little alveoli, all those little teeny tiny bubbles serve to give more surface area. Blood from the right heart entering the pulmonary capillaries is high in carbon dioxide, low in oxygen, and the opposite is true on the other side. Gas exchange takes place and the pulmonary capillary increases in oxygen concentration before traveling to the left of the heart to be pumped around to the tissues. So there's a phospholipid layer, which is like a surfactant lining the alveoli. That helps lower surface tension. So if you've ever, for example, taken a drop of dish soap and dropped it into a glass of water, it breaks the surface tension of the water, right? Because soap is a surfactant. Surfactants break that surface tension, allowing things to pass through more easily. If you ever did that experiment in biology or marine science or anywhere else where you rest a penny on top of a glass of water, you can rest it on top of the surface membrane. But if you put a drop of soap in there, all of a sudden you can't. Everything just drops to the bottom. So that's basically what's happening. The surfactant layer is making sure that that layer is easy to penetrate for the oxygen. Then we have the simple squamous cells. 95% of the alveolar surface is these. So the little flat scale-like cells that we already talked about. All right, then we have the tissue layer, the alveolar epithelium. Type 2 cells produce the surfactant. So that's the fat ones in there. They make the surfactant to help keep the surface tension low. Type 3 cells are macrophages. As we inhale foreign particles and then it gets past that mucous membrane, the mucociliary escalator, these macrophages are generally going to attack. So they kind of just wander around inside the alveoli, and if they bump into any foreign particles, they attack them. Pores of Kohn are small holes between the alveoli to allow movement of macrophages between alveoli. Third component of the alveolar capillary membrane is the interstitial space. So this separates the membranes. So you have a membrane in the alveoli and a membrane in the capillaries. So you have this little space that contains some fluid in between the two membranes. It's super, super tiny. It looks, except under extreme magnification, like they're fused together. But if too much fluid gets in that space, if you get interstitial edema, remember edema is basically water retention, having too much fluid somewhere, it can separate those two membranes, pushing them farther apart. So if you picture the membrane of your alveoli, those little air sacs, is pressed up, almost touching your capillaries in order to allow that oxygen to get right into them. If that fluid in between swells, it pushes them far apart, and it's harder for the oxygen to get across that layer. The fourth component is the capillary endothelium that contains the capillary blood and the red blood cells. All right, so there's lots of different function tests you can do on the lungs. You guys wrote some of these down before the break, so we're gonna go through them pretty quickly. Basically just tell people to take deep breaths and exhale. Normally, when you exhale, you don't exhale all the way. You don't inhale all the way either, but you leave kind of this reserve capacity in there. So if you practice breathing and sit there and just breathe naturally, you're gonna take naturally very shallow breaths. When we're not exerting ourselves, and we're not thinking about it, we generally take fairly shallow breaths. So you can breathe in much deeper if you try. And then if you have a normal exhale and you're breathing normally, if you stop yourself, you can exhale even more air if you try. That's that little reserve volume that's trapped in there. So there's different tests that we do to measure the volume of each lung, the reserve volume, how much you can take in and expel, all those types of things. You can reference this chart for all of the different ones. Pneumonia, lung infection caused by a virus, fungus, bacterium, aspiration, or chemical inhalation results in inflammation of the infected area with accumulation of cell debris and fluid. So Pneumonia is really, really common, especially common in elderly people and people with compromised immune systems, because there's lots of different things that can cause it. Again, you see there, virus, fungus, bacterium, aspiration, which means inhaling something. So say you're eating and laughing or whatever, and you're eating some cookies and you inhale and cookie crumbs go down into your lungs, that's aspiration. Also chemical inhalation, so I'll be breathing in chemicals. So there's lots of things that can cause pneumonia, which contributes it to be really common, especially in people with weaker immune systems, which is old people and sick people and stuff like that. So in nursing homes, it's really common. It's often a secondary infection. Like somebody will get a cold or the flu or something else, could be COVID-19 right now. And because that's already making their immune system weak, they're very prone to getting pneumonia. So some pneumonias destroy lung tissue, and severe pneumonia can result in death. It is a very common cause of death in nursing homes and with elderly people. This is showing you just different types, broncho versus lobar versus interstitial. So the first type means that these individual alveoli and bronchi are affected by the pneumonia. In this type, in lobar, there's a particular lobe of the lung has an infection, but it hasn't spread to the others. And then interstitial, that's the one we talked about a minute ago, where if the fluid swells in between the air sacs and your capillaries, you don't get very good oxygen exchange. Tuberculosis, we talked a little about this before. It's an infectious disease that thrives in high oxygen areas such as the lung. The lesions that form in them are called tubercles. That's why this is called tuberculosis, condition of having tubercles. The bacteria can lay dormant for years. So you can get a test, and most people should occasionally get tested to see if you are a carrier of tuberculosis, because you can be completely asymptomatic with it being dormant for years in your body before you actually get it. Or you may never even show signs of tuberculosis, but you could still potentially give it to somebody else. Unchecked, it can cause really extensive lung damage. It's treated with medication, but there is a resistant form that has been appearing lately. So you guys remember we watched that video about tuberculosis and how it was such a big killer in the not too distant past before we came up with treatments and better hospital care. But now we are seeing resistant forms becoming more and more common. So there's a possibility that we see a second wave of tuberculosis that's drug resistant that could potentially cause another epidemic. Has a very high mortality rate. COPD, you guys did this for a question on Google Classroom. General term for conditions associated with cough, sputum production, dyspnea, airflow obstruction, impaired gas exchange. It's the fourth leading cause of death in the United States. It's not really one specific thing though. So it's a little bit misleading to call it fourth leading cause of death, but it is. Just know that it includes a lot of different things. It's a group of diseases in which patients have difficulty getting all the air out of their lungs. There's often large amounts of secretions and lung damage. So you could have damage to your lungs. You could have too much mucus in your lungs. You could have that